Okay, thanks Jim. Thank you everyone for coming along today. As Jim said, smoking isn't really one of my main areas of research, but it was an interesting project to get involved with, and also it's been very interesting in terms of working with a slightly different population of people. So the title of this presentation is Can Anti-Tobacco Industry Messages be Used to Reduce Youth Smoking in the UK? And the reason that this project was initiated was because there's some evidence from the States in particular to suggest that interventions that actually target the tobacco industry and talk about how the tobacco industry tries to manipulate people into smoking actually has the impact of turning children off smoking because they feel like they're being manipulated. But there's very little work done in the UK on this, and so we were commissioned by Smoke Free North West to do the research in collaboration with Curiosity Research. So the whole intervention, the whole idea of this intervention hinges on tobacco industry denormalisation. And I'll just explain what that is. Here's a quote which I think sort of provides a good definition of it. It's looking at activities which are undertaken specifically to reposition tobacco products in the tobacco industry consistent with the addictive and hazardous nature of tobacco products, the health, social and economic burden resulting from the use of tobacco, and the practices undertaken by the industry to promote its products and create social goodwill towards the industry. So it's trying to suggest that we see tobacco and tobacco products as a normal product in society, but why should this be the case if it causes so much morbidity and mortality? Why should we be seeing tobacco as just a normal product? And shouldn't we try to be seeing it or paint in people's minds a picture of the addictive nature of tobacco and the harmful nature of tobacco? Now, a lot of the work's been done in the States, as I said, and the biggest sort of campaign over there was called the Truth Campaign. And I'm just going to stop my presentation now because what I'd like to do is just show you a couple of adverts that we used in America as part of the Truth Campaign, which I think really shows you what the American campaign was trying to do. So I've got a couple for you, and it'll provide a bit more context for the research as well. Okay, so we'll go through them. Okay, so that's the first one. You'll see that they're all quite different because obviously they try to appeal to different audiences.
At Shards on Glass Freeze Pops, we want you to know where we stand on important glass freeze pop issues. For example, we now agree there's no such thing as a safe glass freeze pop. They are addictive and can cause serious health issues. In fact, 1/3 of the people who enjoy our product will eventually die from shards-related ailments. The only proven way to reduce health risks from our glass pops is to not eat them. For more, including information and links on how to help quit our glass freeze pops, visit our website at shardsofglass.com. And remember, Shards of Glass Freeze Pops are for adults only.
Okay, so again, quite a high quality production. Just show you two more.
In 2006, a federal judge found out that heat smokers addicted big tobacco manipulated nicotine levels. But too much nicotine can make you sick.
That's why they need the magical amount. Too much nicotine might make you sick. Not enough, you might quit and walk away.
Looks like they got the right amount to keep the smokers smoking all the
Seriously?
Okay, one final short one, which I think is more along the lines of we would think of a traditional anti-smoking campaign.
Tobacco company shooting images of what life would be like if you smoked.
They tell you tough, hard-working people smoke their cigarettes.
That you look cool, hip, and rebellious.
When smoking makes you independent, beautiful, and mysterious.
But the reality is that you can end up looking like this.
Okay, so that provides a bit of context to show you what we mean when we're talking about denormalising tobacco products in the tobacco industry. So the objectives of the research that we're involved in was to review the literature relating to tobacco products and denormalisation interventions, to identify young people's understanding of and attitudes towards the tobacco industry, to test reactions to and understanding of tobacco industry denormalisation adverts like the ones I've just shown you, but we showed them a whole host of other ones as well, and messages, and to ascertain whether tobacco industry denormalisation strategies could play a role in the UK in reducing youth smoking and the practicalities of such implementation. And for this presentation, when we're talking about young people, I'm talking about people aged 11 to 17. Okay, so just outline of the methodology. We conducted a literature review, we did classroom discussions. Originally we were trying to do some focus groups with young people. However, logistically, schools preferred us to do the whole class rather than take individual pupils out of classes, just because of the logistical reasons, as I say. So we had to just do more broad classroom discussions and more sort of focused focus groups. We did interviews with potential providers and promoters of these interventions, and we did some interviews with international tobacco control experts. Now, colleagues that I can see sitting in the room, Ellie and Lisa, very kindly did the literature review. They're in the systematic review team. They reviewed 333 papers. The two reviewers screened the titles and the abstracts. 250 papers were excluded. 76 papers were retrieved for full screening. 49 were excluded, and that left 27 papers which were selected for review. But they did also search the grey literature and some of the websites as well. And of the 27 papers, 16 examined the US-based Truth campaign, so that's the campaign I've just talked about. Of those, 11 examined the National Truth campaign, and also 5 examined the Florida Truth campaign. 4 examined other statewide campaigns, and 7 were experimental studies. So you can see the evidence base all comes from America. And it was interesting what David was saying about interventions not necessarily just being able to take them from one country and plant them into another. We had to bear in mind that all the evidence comes from America, and that's why Smoke Free Northwest were particularly interested in commissioning this piece of research. So there were some interesting findings from the literature review. There was definite evidence to show that the Truth and similar campaigns do have an impact on attitudes towards the tobacco industry, attitudes towards smoking, and on smoking behaviour. Obviously, you know that when you read in academic literature and people say, oh yes, it's going to have an impact, it's not as good, obviously, as actually measuring people's smoking behaviour. And there was some evidence to show that it did actually have an impact on smoking behaviour as well as just attitudes. Anti-industry advertisements could be recalled by people. Messages that focused on the negative health effects of smoking and smoking-related negative life circumstances had the biggest impact in terms of intention and recall. The intensity of the campaign was very important. So while the campaign was running, people had very good understanding and memory of the campaign, but once the Truth campaign had stopped its advertisements, then the impact tended to wear off. The effectiveness varied by subgroup. So, for example, there was one study that found that young people from areas of lower educational achievement were less aware of the Truth campaign. One study found that campaign with multiple elements were most cost effective, and indeed that is supported by CDC guidelines on tobacco control programs. But bearing in mind that all the evidence basically came from America, and of course, as we know, that American adolescents may be very different from UK adolescents. And also in the UK, we've had the Tobacco Advertising and Promotion Act with us since 2002, which means that it's legal to advertise tobacco products. And of course, there's no such ban that exists in America. So it's likely that the two different contexts are quite different. So, as I say, the first element of the primary research was to do some classroom discussions. We did 10 classrooms, and they were across the whole of the Northwest. They included both rural and urban populations. They included young people from the age of 11 to 17, as I said, including 2 classroom discussion groups that were in colleges. And we tried to get a range of smoking behaviours as well, but obviously because we wanted the whole classroom, or because the school wanted us to look at the whole classroom, we didn't want to ask about smoking behaviours to start with, because obviously we didn't want to put the children on the spot. So we don't really know how prevalent smoking was. But most of them certainly had quite anti-smoking attitudes. So, as I said, there were relatively low levels of smoking initiation amongst all age groups, and most had a relatively strong anti-smoking position. So quotes included things like, "It's the quickest way to die." Most respondents understood that smoking caused health problems, and this did appear to be a strong deterrent to smoking. So it was definitely the health messages that seemed to be communicated to young people over the years in relation to smoking had certainly hit home. Maybe not surprising, they had no recall of tobacco advertising and little memory of smoking awareness before the ban. And most respondents had, at best, only a basic knowledge or awareness of the tobacco industry. And I should say, probably to set the context here, whilst we still know that a number of young people smoke, we have seen falling prevalence rates of youth smoking in the UK. So I think that some of the findings that we're sort of detailing here actually reflect that there's been understandably a lot of efforts put into reducing teen smoking anyway in recent years. Okay, we asked about the message. If we're going to, we provided them with some facts and myths, if you like, about smoking, and we asked them to say which they thought were facts and which they thought were myths. And they were very clear about which were facts. Health information and messages were recognised, understood and believed. And I think that just reflects the fact that a lot of the work that's been done in recent time has actually focused on the health consequences of smoking for understandable reasons. Some messages were considered more relevant, for example, if they could be associated with the consequences. So, for example, even the very young girls at the age of 11 or 12 were interested about the damage that smoking can do to fertility and unborn babies, and also some of the girls were very interested in the effects of smoking on their looks, for example, smelling and poor teeth and things like that. Messages with clear facts and figures which were shocking, were more shocking and effective. So, for example, one of the facts that we gave them was the number of smoking deaths comparable to other major causes of disease and illness that affected them, so for example, road traffic accidents, suicides and HIV. And those are the kind of factors that hit home. So if you make them relevant to the person, those are the ones that they kind of resonated with. Most said smoking was addictive and definitely not cool. And they didn't feel any peer pressure from their friends to start smoking. Having smokers at home tended to make them more anti-smoking. However, if they had an older sibling that smoked, then they were slightly more likely to influence them starting. However, of course, these are classroom discussions rather than sort of quantitative research. So then, of course, we introduced this idea of denormalisation, tobacco industry denormalisation, and showed them some of the clips that we've just seen. Now, unprompted, the concept created little reaction, and many respondents didn't understand the purpose of the advert shown to them. Now, shards of glass I thought was a really good one, but not if you don't really understand how addictive tobacco is and how poisonous it can be, etc. So some of them did not understand the shards of glass at all, unprompted. Once the tactics of the tobacco industry had been explained to them, there was a real sense of anger and exploitation amongst some of the respondents. So quotes said things like, "I feel used, they're trying to kill us faster, and I bet they don't smoke." Because there's a lot of evidence historically to show that the tobacco industry actually deliberately tries to get young people to start smoking, because obviously as older people die, then they want, or stop smoking, they want to get younger people to come through and take up the habit. And tobacco companies aren't quite so transparent anymore, but I'm sure the practice does still occur. And so when the young people were shown some of those and shown again some of the adverts, they kind of got what we were talking about. However, the majority of respondents still remained largely ambivalent to this as an approach. Most respondents were not aware of third world exploitation or the environmental issues, and by that what we were trying to do was to kind of link the tobacco industry with cash crops and exploitation in the third world. And some of the people we talked to understood that, and some of them just really didn't get the connection at all. Many respondents thought that tobacco industry denormalisation interventions are useful and feasible, but they need to be part of a wider approach to reducing smoking among young people, and that it should not replace health-based prevention messages. So the most popular and appealing films, once there'd been a bit of more discussion, were the ones that we kind of showed you today. So tobacco-related death, I didn't show you because that's quite long, but the Shards of Glass, which was the ice cream one, lollipop one, the body bags, which was them lining them up outside the tobacco industry, and the Camel Cowboy, which was supposed to be, you know, glamorized smoking. Those are the ones that eventually they decided that once they'd had some explanation, those are the ones they liked best. Mainly because they said that they were shorter duration, clear and simple information which they could understand, and shock and health consequences again. So it's definitely tying it back into these health consequences that people thought were most relevant to them. Humour, they felt, was a means of getting their attention in the first place, but it was the shock tactics that really worked and kept them interested in the videos. Okay, so the second element of the work was to do some interviews with people who might deliver these interventions within the Northwest region. We did 8 interviews with a range of individuals. So, for example, it would be a specialist, public health specialist and a PCT that was charged with looking after tobacco control. We had 2 youth workers, we had teachers, etc. So we had quite a range of individuals. We had a healthy school coordinator. So we've got a range of views. Generally, there was quite good support for this approach as part of a wider programme to denormalise smoking. So, for example, smoke-free sports and smoke-free films are other initiatives that are trying at the moment just to come at this from all different kinds of angles, really, to really try and denormalise smoking. They thought that different approaches in combination would be most successful, and as I said before, that does actually support CDC guidelines for tobacco control. They thought it was a useful approach because it focuses on the industry rather than the individual. What we get sometimes when people, if you're the person that's carrying out a behaviour, such as smoking, and you're the one that's being told constantly, it's bad for you, you shouldn't. For some people, they become more, you know, sort of ingrained in them. They're kind of a little bit like, right, I'm going to even more likely to carry out this behaviour because you're telling me to stop. And one of the people said that this is quite an interesting and useful approach because it targets the industry and not the individual's behaviour. They thought that the organisations in the Northwest could come together and learn from their experiences because they have been trying to pilot this in the Northwest. There's some lobbying groups that were trying to get together to encourage children or young people to sort of speak together about this as an intervention and see if they could get lobbying groups sort of initiated. And they also felt that there was definitely experience and expertise to deliver this approach in the Northwest. So quotes included things like, talking about the tobacco industry things, you're not directing it at them, it becomes depersonalised as well as telling them things that they've not been told before. And if you do things at a number of different levels in the strategy, you have more chance of success if you focus everything on one thing like changing individuals' behaviour. Okay, obviously we asked about what the message should be, what kind of information should we be providing. Maybe no surprise it has to be relevant to the audience, which means tailoring it to different ages and different abilities, non-judgmental. The kind of words that people use to describe what they thought should go into adverts, if we're going to go down this line, would be snappy, short, humorous, personal, eye-catching, have an emotional impact, health-orientated, not health-orientated, involving sex, because they thought that everything to do with this group would be probably taken on board if they could hook it onto sex. So you can see there's a lot of different sort of attitudes, and this health-orientated, not health-orientated was an argument that came up quite a lot. Because for some people, they thought that the health-orientated messages were the most important, and certainly the children themselves seemed to think that that was the case. But for other people, they said, oh, if you tell someone they're going to die of lung cancer at the age of 60, no one cares. So there was quite, you know, diverse opinions on whether the health messages were the right way to go. And another person said that you could involve a famous person, because obviously celebrity culture as it is now. So quotes included things like, health messages stick with the younger side of young people. It's the immediacy and the gruesomeness which appeals, I suppose, and opposed to mind games that they might be playing with them. So that basically refers to somebody thinking that it wasn't really that important to target the message specifically at the industry and saying they're being manipulated, but it was more important to focus on the health messages. The more gruesome, the better. But then, contrary to that, the third quote, I think sometimes that with young people, the messages about health don't get across. But I think if you start talking about Do you know that you're being manipulated, or have you thought about the ways in which the tobacco industry get you to smoke or get you to think about smoking? Young people pick on those more readily. Okay, we asked about whether they thought that there was an age appropriateness for these kind of interventions, and the general feeling was appropriate for all ages, but obviously it needed to be tailored accordingly. But most felt it was most appropriate for secondary school age because they're learning how to debate and are more aware of manipulation means, and because it's a more sophisticated message. And also they felt that the groundwork needs to be carried out because some young people would have little knowledge of the tobacco industry, and indeed that was actually borne out in our classroom discussions. And it was more about the educational ability, and the knowledge of the child was more important than their age, which I think was borne out with the initial study as well. So quotes include, you've got to be very conscious of the way you present it in a way that young people can understand. Obviously that makes sense for all interventions. I think that it's really important that they target people from a very young age. I think particularly with the 11 to 19 age group, they completely understand the message. And the final, I don't mean that I don't mean that under the age young people won't get the message, but I think about the age of 11 upwards, young people get a bit more indignant about being cajoled or tricked into doing things. Again, this is just more about the age. I don't think that they have much understanding of the tobacco industry. I don't think they've even ever questioned where cigarettes come from. They're not even really probably aware that tobacco is a plant. I certainly think people are ready for it, and that's something new and we should try it. But yeah, I think there's a lot of work to be done. And a similar kind of comment says, I think it goes deeper than just saying sixth form or key stage 4, key stage 3. I think you've got to look at the type of the kid who's sitting in front of you as well. So there's very much an identification that the young person must understand something about the tobacco industry before they actually try this approach. Okay, then we asked them about a number of barriers and facilitators. So barriers for schools, if the intervention was to be delivered in a school, some barriers would obviously be time pressure on the teachers to focus on the intervention. We all know that they've got national curriculum and there's not much scope outside of that to provide some of these interventions. And also the training of the teachers. It's all very well if you've got the best intervention in the world, but if the teachers that are delivering aren't very good, then it's not going to work. And also things like Facebook, YouTube, it's blocked in schools, so if you're going to go down that route, then that might be difficult. Facilitators for delivering these kind of interventions in school would be to have resource packs of films, activities, quotes and statistics, for example, all ready there for a lesson plan, so somebody just pick it up and run with it. Use other staff rather than teachers to deliver the interventions. So again, most schools now have got healthy schools coordinators, so possibly tie in with that structure. You do not have to focus solely on lessons like PSHE for these kind of, to deliver these kind of interventions. You could incorporate the message into geography or history or sport. So for example, in geography, you could start teaching people about exploitation of lower income countries and bringing the tobacco industry as part of those discussions. And also the school, the school can also create an environment that fosters discussion. It's an opportunity, or classrooms can be an opportunity for people to sort of debate things. So just some quotes around that. Something like this would come low down in a normal teacher's week. We do have people like health coordinators who would have more of a focus and can do the bigger picture. But a form tutor is they would need things to be ready and done, otherwise they will get dismissed and we move on to the next thing. If someone was new in post, they could pick up, package with photos, quotes, etc. One idea would be to target the Healthy Schools award system, try to take the message not just during PSHE and spreading the message in time to get into different areas of school and the general school population. Okay, there was also discussion about barriers and facilitators to actually trying to set up youth groups to be activists for this kind of approach. But it was difficult to bring these groups together. People that had experience before thought it was a bit difficult to bring young people together because they don't always necessarily able to focus or concentrate that much time on it. A one-year funding cycle was a barrier to longer-term implementation. Awareness of the political environment and getting activities agreed was also difficult. The thing is, of course, the tobacco industry is quite large, and so you need to be powerful, and so you need to be careful that you're not inadvertently causing difficulties for yourself by sort of tackling this as an issue. Facilitators would be to keep in regular contact with them via text. You could consider paying the young people to participate in youth groups, fun, exciting activities in addition to lobbying. Have to have young people to develop the materials, etc. So again, I was talking about the message is most important, to get the young people themselves to develop those messages. And linking in with regional campaigns would help logistically. We talked about what delivery channels. Obviously, there's a lot of different ways that we can get messages out to people, and we thought it would be interesting to find out how they thought would best approach this. They talked about a raft of interventions or delivery channels which all be necessary to reinforce the message. We can't think of young people as one homogenous group, but we need to be thinking about how we can get in contact with different groups of young people by different channels. So people came up with Facebook, Twitter, the internet, Bluetooth messaging, pop-ups, and people log onto their PCs, etc. One interviewee felt that the internet was only useful if the person was seeking information rather than just like trawling for information. Obviously, the local and national media was identified, but this hits a large swathe of the population, but it's very, very costly. Peer education was viewed favourably, but it was felt the educators themselves benefited most, and this approach was not very cost effective, or at least costly due to the continuing support. So that's basically when you get young people, you train them up to be peer educators and go out and spread the message amongst their peers, but that is quite labour intensive. Teachers, etc. would be good, providing that the intervention was right, and that young people tend to have a small radius of influence, and intervention should be targeted locally but supported by a regional national campaign. Okay, so quotes to go with that. I think the problem with advertising is that you need to inundate areas with advertising of all kinds that people and even young people see it enough times to feel it's having an impact, and I'm not sure we've got the funding or the ability to be able to do that. The problem with peer education is that it's so resource intensive. You do need staff alongside it. It's not something that you can just leave and go off and happen by itself. And I think it needs to be a mixture of probably all of them, but particularly the mass media, so your YouTube, viral, coupled with, if you could, some kind of more localised intensive type training with young people. Okay, so just very briefly now, the final little bit is that we did some interviews with international tobacco control experts. We did 4 interviews, 2 were in the UK, 1 America and 1 in Australia, where also they've got a very, quite a good history now of tobacco control. So the international experts definitely thought that anti-industry approaches were effective and that they should be tried in the UK. So to summarise, the quotes support that. It's very important because there's quite good evidence among both young people and young adults that people who don't trust the tobacco companies and don't like the tobacco companies are less likely to smoke. And if they're smokers, they're more likely to make a quit attempt, so it's very important. Most people quit unassisted, and the strongest predictor of cessation efforts are the number of times you try, and industry denormalisation messages stimulate quit attempts. I do think there's scope for this, and I think it's one thing that we haven't tried, and we have to be continuously innovative in tobacco control so that the rates don't go back up again. Now we asked them what kind of tactics they thought that the tobacco industry used in terms of marketing its products. If you think about now, as I said, there's a ban so that tobacco companies aren't able to market their products in the UK, but the international experts definitely thought that tobacco companies were still marketing but via different routes. So, for example, they thought there were a range of methods which were used, such as internet approaches such as YouTube product reviews and Facebook groups. So basically, the quote summarises this in a little bit, but you know, if you go onto YouTube, you've got no idea who put that up, so it could very easily be something that is funded by a tobacco company but isn't overtly funded by a tobacco company. So it's very difficult to see on the internet who's funding what. They thought that the tobacco companies funded libertarian groups, so groups which were interested in being able to carry out their own behaviours. So there were some groups that were funded by the tobacco industry, so it was kind of like a devious route to get into. So people saying, well, I should be able to do what I want, and the tobacco industry buying into that kind of idea. Tying smoking with fashion, music and films. I don't know whether people saw not so long ago Kate Moss walking down the catwalk with a famous brand of cigarette. Product innovation, so always looking at different packaging that maybe appeal to young people. Packaging that appeal to young people, next point. So this is quite a long quote, but I think it summarises nicely what some of the people were trying to say. So the internet is not regulated, and legislators don't understand it, and it's quite easy to be anonymous, and it's quite amazing just how much pro-tobacco and pro-tobacco brands are online. And I think that, you know, if you're on Facebook and you're a smoker, You can very easily find fan groups and pages of your favourite brand. That's quite covert, and it's very difficult to pinpoint if it's the tobacco industry who's behind or there's just enthusiastic smokers doing it off their own back. Same as YouTube, you can find all kinds of product reviews or videos of people smoking, say the name cigarette and say the new cigarette and like, oh, it's so great, I love the new package, stuff like that. And again, it's very difficult to pinpoint that it's being funded by the tobacco industry directly. Now, obviously, being involved with this study, I went on YouTube and Facebook and things like that, and there are actually a surprising number of clips, etc., that are talking about people smoking, saying how fabulous it is. So, in talking about the age, 2 interviewees suggested that tackling adult smoking was actually the best way of reducing youth smoking. And 2 interviewees suggested that anti-industry approaches were suitable for all ages, that they qualified this by saying that the starting age should be about the age of 12. So it's been about population media campaigns that appeal to everybody, and the side effects is that the youth smoking rates go down. You reduce adult smoking rates, smoking rates go down, and that's sometimes hard. The hard sell for politicians who are all, yes, yes, we must combat youth smoking. The best way to combat youth smoking is to actually do something about adult smoking, to properly denormalise it so it's not actually an issue in society in general. So the message, the important first stage, people felt was to ensure that people understood the link between smoking and disease. They felt that a lot of young people will be aware of the link between smoking and lung cancer, but they thought we need to spend much more time talking about the association between smoking and other aspects of health, like coronary heart disease or cot death. However, another interview contradicted this by saying that health outcomes were too dissonant to resonate with young people, and that's again that difficulty of identifying. Some people were very much in favour of health messages, some people just thought they were too irrelevant for young people. When testing messages that are jarring and annoying should not be discounted because these are emotions that are associated with better recall. So if you're doing focus groups, etc., and you're trying to test some of the messages, one of the experts said, if the young people don't like it, don't assume that that means it's a bad message, because it actually could be the ones that stick with them for a duration. So quotes to sort of summarise that. If you look at the international evidence on mass media, it's saying there are certain messages that play better, which is the nasty health impact on the tobacco industry. And then conversely, so if you want the young people to engage with tobacco control issues, then telling them about heart disease and lung cancer in the late 50s is really not to get very far, because they're simply not going to relate to it. It's not going to align with their values. On the other hand, telling them that they're being duped and hoodwinked by an industry that exploits child labour, that has a much greater chance of resonating with them. But that was exactly what we didn't find in our research with the young people. We found that the health messages were really interesting to them, and when you talked about child labour, about people in places picking the tobacco plant, didn't really have any effect at all. So in talking about whether we should think about implementing this in the UK, the experts said that the first stage would be definitely to educate people about the tobacco industry and its tactics, and again that slightly supported some of the work that we did in the classroom discussions. They also felt that we should follow exactly what was done in the UK, in the USA, because it has been successful. Then really it should look at the steps that were carried out in the USA and see how that approach can be implemented here. It is important to note that the USA-based campaign were incredibly well funded. Those the Truth campaign adverts, they had a lot of financial support behind them. The media is important, but can be used more creatively. So, for example, one of the professionals that we spoke to actually said that you could voice an anti-industry soundbite every time you have the opportunity to speak publicly. So, whenever somebody's speaking about the tobacco industry, maybe on the news or something like that, then they have the opportunity, because they've got all the cameras on them, they have the opportunity to sort of talk about the anti-industry sort of messages, as well as just talking about the health implications. And indeed, an anti-industry message could be included in all tobacco control resources. Interviewees stated that the intervention should be properly evaluated in order to add to the evidence base around industry denormalisation approaches to tobacco control. So just a couple of quotes. If you want to move along in an anti-industry direction, you have to first educate people about what is going on and what the industry is doing, because it's largely hidden. And then I know other states, Massachusetts, their denormalisation campaign stood out as one of the reasons why their youth smoking went down. But, and it's a big but, there was an incredibly well-financed campaign. It wasn't a case of, oh well, we'll just make a commercial, pop it on the television, problem solved. Okay, so just some findings. The evidence review shows that tobacco industry denormalisation strategies have the potential to impact positively on smoking attitudes and behaviour. Potential providers and promoters of these kind of approaches and international experts stated their support for anti-industry approaches, but as part of a raft of interventions. So they certainly didn't think that these kind of approaches should take over from existing interventions that already seem to be working, seeing as we know that smoking rates are coming down. There was a lack of awareness and understanding by the research participants of the tobacco in advertising, tobacco companies, or the tobacco industry tactics used to target young people. So there's somewhat of a paradox exists in terms that anti-industry approaches should be initiated at a young age because that's when people start to smoke. However, the anti-industry messages were less well understood by the young people of the ones that we interviewed that were aged less than 18, or at least the ones, there were some individuals that were participated in the classroom discussions which did get it, but they tend to be the more educated ones. So once prompted and informed, it was possible to create strong emotions of anger and exploitation and defiance against the tobacco industry and its marketing activities, but only amongst some of the young people we talked to, and certainly not all of them. And some investment in educating young people, such as defining and explaining the issues clearly, would be necessary with young people in order for their awareness levels to be raised and for the anti-industry messages to have an impact. The educational process need not be lengthy, but it would like to increase the effectiveness of any anti-industry campaign. So in the hour or so that we had the classroom discussions, we went from no understanding to reasonable understanding for some of them within a short period of time, but we did feel that that educational process is needed to lay the groundwork if this intervention is going to be actioned. So the health messages were really well understood by research participants, while the evidence base also showed that negative health effects had the greatest impacts in terms of recall and intention to smoke. And it's important that people understand the association between smoking and a range of health outcomes, particularly those that are of greatest relevance and immediacy to the young people. So as we said, it was more, the messages that they found were really useful, were really interesting, was the ones that for the young women particularly was that focused on like fertility. The quality of the message in terms of its ability to resonate with and impact on the target audience will be paramount to its success. However good the intervention is, the delivery, etc., it's those adverts that are going to be crucial to it. So you need to make sure that those which the whole intervention would hang on, those need to be of a good quality. There are a number of effective routes to reach this audience, such as the mass media, word of mouth, social networking, and school-based interventions. School-based interventions were where education can be provided, supported by wider advertising and social networking, appears to be the most effective route to reaching respondents in accordance with our research findings. And it was suggested by stakeholders that tobacco industry uses the internet widely to market covertly to young people through Facebook groups and YouTube videos, etc., although we were not able to collect any specific evidence. However, if this is the case, we would support the use of social media as a route to reach and effectively communicate with the audience. If you think about it, the tobacco industry is very well funded, so if they're using social media, they've obviously done the research to identify that this is an important role in terms of reaching people to start them smoking. So maybe that's where we start in terms of using a vehicle to actually use a vehicle for these kind of interventions. And then finally, and most importantly, any anti-tobacco industry intervention would need to be very well funded. As I said, the Truth campaign certainly was, and it's going to be similar resources if anything was tried in the UK. Okay, that's done.
Okay, thanks for that, Jim. You'll be happy to hear that I won't be talking about an effectiveness trial for preventive intervention. I'll be talking about something slightly different. It's a project that Harry Sumner and I have been working on over the last 3 years or something, and it's finally coming to an end, so I'm very pleased to talk about this today. Just to give you an outline of the presentations, to tie in with the previous two presentations, I'll talk about some of the challenges of disseminating evidence into practice. I'll then go on to introduce the Prevention Standards Project, the standards themselves, just very briefly, and then talk about the impact that this project has had already and that we're hoping that it will have in the future on EU policy and practice and beyond. And then I'll finish off by telling you about our next steps. So let's start with some challenges, or rather some conditions. And if I was David, then I would have a cool thing with zooming in and zooming out of these triangles. The point is basically that I've just outlined some of the conditions that I think are pretty important. The quality and availability of evidence base, the existence of well-developed delivery structures, and an evidence-based cultures among policymakers and practitioners. And in a way, this is also a way to summarize today's presentations, because David was talking about the evidence base, and he was also highlighting at the beginning of his presentation the problems around there not being many high-quality studies, that evidence is often inconclusive. So even there's lots of stuff going on, at the end of the day, you're often left thinking, well, what am I actually supposed to do now? On top of all that, research findings require adaptation. So if something was done in the US, it has to be adapted to the circumstances here. That's what Carol's study was about as well. And even so, at the end of the day, we often lack step-by-step guidance. Just by hearing these presentations, you wouldn't know how to do drug prevention now yourself. Carol also touched upon delivery structures. So these are issues about funding, for example. Who are the big players? Who determines what are the priorities, where money is invested? But also, for example, in schools, whether there is actually a dedicated space to do prevention. And the reality is that, for example, a drug treatment receives far more attention than prevention. There's also a lot of duplication and fragmentation of work. So people are not actually aware of what's going on elsewhere. Everybody's doing something. It's just not very well coordinated. And then at the top, we've got evidence-based culture. There's often a skepticism among practitioners and policymakers when they hear evidence-based, because the evidence to them is their own personal or professional experience of what they have seen that works, or what they think works, or what they think is good. There's also often a false perception that evidence-based approaches cost more. So while the stuff that has been presented before is very important, there needs to be also other activities in place which can improve and contribute to the conditions that are necessary to implement evidence-based approaches. And there's several ways of doing this, and I'm going to present today the way that we have followed. So one possibility is to develop and introduce technical quality standards which address not what you do, which is what the previous two presentations were about, but how you do it. So they address the more structural, the more formal aspects. And this provides, on the one hand, formal guidance on how to do activities in the absence of more specific content guidance. So this is important for organizations who are already doing drug prevention. So they're obviously doing something. And these standards can then help them to determine how they can improve what they're doing already. In terms of delivery structures, it would ensure a minimum level of quality of existing structures and services, support the promotion of prevention activities, and it can raise the awareness for the need for evidence-based approaches in quality assurance systems. And this is where we get to our project. This was a two-year project co-financed by the European Union, with LJMU as the project lead of what has become famous as the Prevention Standards Partnership, a international collaboration. We were the only university in this partnership. There's quite a few government agencies and local health agencies, and the European Drugs Agency at the bottom, which has played a vital role now towards the end, but I'll come back to that later. The project originally started because there was exactly that insight. So actually we're lacking some sort of overall framework of what we're trying to do. There's some guidance from the scientific evidence base, of course, but it's, as I said, often inconclusive. Then there's like regional and national quality standards or guidelines, but it's never quite clear what they're based upon. Can we apply them to other EU countries? So what we were hoping to achieve was to sort of summarize all of this and to provide a framework that policymakers and practitioners could use to orientate their working. How were the quality standards developed? Initially, we collated and reviewed existing standards. That's always the easiest way to do it. Why do something from scratch if you can build upon something that someone else has done? We identified 77 documents from the EU, but also internationally, again, North America mostly. And 19 documents were selected where we extracted the quality standards and summarized them into a really long list. And this was our first draft. And then we presented this first draft to drug prevention professionals in the 6 countries that took part in this project. It's important to mention that when I said drug prevention professionals, I don't mean people who do only drug prevention all day. It was quite important for us to target people who have some role in drug prevention, but maybe it's not the main thing they do. So we contacted teachers as well as media professionals, but of course, as you would expect, like health professionals, people working in government, NGOs. So we had 400 people complete an online survey of what they thought about the draft standards, and then we had focus groups where we had detailed discussions about how the standards may be useful in practice, whether they're realistic, how they could be implemented, and then we came to the final list of standards. I'm just going to present this very briefly because if you're more interested in the actual content of the standards, then that's something that we can tell you about separately. But at the core, they're organized as a project cycle because we found that this was actually the most intuitive and easy to understand way to structure standards. So standards cover all sorts of topics from a needs assessment within the community and the target population, resource assessment, also of internal resources, so what can I actually do? Program formulation, where you say what is the sort of what are the aims of the intervention, what's the evidence base you draw upon, the actual intervention design, which also covers things that Carol was just talking about, such as tailoring it to the target population, making sure it's relevant, the management and mobilization of resources, staff, finance, recruiting the target population, all the things that you often forget but that are actually really important. Implementing the interventions and monitoring its success, then the final evaluation, and drawing the conclusions and starting the project cycle again. In the middle, we've placed what we've called the cross-cutting considerations. They're things that are always important and that therefore originally we had them in the project cycle, but the consultations showed clearly that they should take a central role. So these are issues about sustainability and funding, communication of stakeholder involvement, staff development, and ethical drug prevention. So they're not the things that you think of immediately when you think of evidence-based approaches, but they are very important. Within each of these project stages, there are the components. So I've just dipped into those first 4, and then the list goes on. There's 35 in total. So they're the actions, basically, that you should take at each project stage. And this is what the standards actually look like as a little booklet. We've got on the top the component title. So here, for example, knowing drug-related policy and legislation. Then we've got the implementation considerations, and these are basically the summaries of the questions or answers to the questions that people asked us during the consultations, and sort of also preempting any criticism where they were saying like, oh, well, this standard wouldn't be relevant to my particular project, because people are always very they always seem to think that their project is special and that these standards, no, they're too general, they wouldn't apply to it. So this is sort of tapping into that a bit and saying, well, it would be relevant in such and such context. And then on the right-hand side, we've got the actual standards. So these are the sort of statements or examples of how they would be evidenced or what you sort of expected to achieve within each of these actions. We've called them attributes. And in keeping with what I just said, all the sort of skepticism that we faced in developing the standards, we've split them up into basic and expert standards. So the basic ones are the ones where we've sort of achieved consensus that this is really what everyone should try to achieve. Even if it's just a school who obviously does other things as a priority, not just drug prevention. If they were to do a drug prevention intervention, they should still adhere to these basic standards. And then once they have achieved that, or in the case of organizations who are well-funded, or interventions that are rolled out by government at a national level, they would be expected to adhere to the expert standards. So in this example, knowing drug-related policy and legislation, everyone would be expected to know about the relevant drug-related policy and legislation, but only at an expert level would they be expected to comply with international standards and guidelines in prevention, because you couldn't expect it from a local school project. We've also got examples to clarify the meaning. The recommended uses of the standards, so it's quite obvious that you can use them to plan new interventions, to reflect on ongoing interventions, and to evaluate completed activities. We also found that you can actually use them to think about people, organizations, and strategies, because things like sustainability and funding are probably more important at an organizational level rather than rethinking that for every individual intervention. There's quite a few different ways of using them. For example, as a learning tool to test your own knowledge and develop your own knowledge of drug prevention, to develop and update quality criteria. That's something that's of relevance to policymakers and funders, and so forth. What you won't see on this list is anything to do with formal self-assessment or numerical assessment. People ideally would like to have some sort of tool where they can give numbers, add it up. If you're under 60, you don't get funded. If you have over 60 points, you do get funded. But we found in the consultations that that requires an awful lot more work, because if otherwise there's a danger of, for example, favoring big organizations that have a lot of money, because obviously they'll be in a much better position to achieve all of these standards. So what are we hoping to achieve, and what have we achieved so far? So the potential impact of the standards, we've sort of got three targets. On a policy and practice level, we're hoping to improve drug prevention practice. So, for example, issues around sustainability of interventions, because Carol also mentioned before this one-year funding cycle that many practitioners feel inhibits them in doing anything long-term, and also constant staff turnover makes it difficult to sustain interventions. On a target population level, to ensure that interventions actually have benefits and that they don't have any harms, and that they're also relevant to the target population, because there is this thing where we're doing drug prevention onto people because it's good for them, but that's not the right approach, is what we're saying. It should be something that's a collaboration where people actually see the benefit of it. And in terms of research and evidence base, we're hoping that the standards will promote a more, will promote further good trials and improve the European evidence base, because as we've heard, a lot of evidence comes from the US, and this is done by including standards around referring to evidence, conducting outcome evaluations, and so forth. And what I mentioned before was that we've been collaborating on this with the leading EU drugs agency, the European Monitoring Centre for Drugs and Drug Addiction. And they've been really supportive in this last part of work, because they actually paid for a beautiful manual to be produced, which includes all the standards. And this manual will be launched next month in Lisbon at the conference of the European Society for Prevention Research. And this will be basically our first step of bringing this out to Europe, dissemination. There will be a website with further supporting materials available that, for example, considerations for local implementation. Speaking of local implementation, out of the 6 project partner countries, in the UK the situation is a bit more complicated, but in these 3 countries they've actually been able to start the process of introducing this document. So they've started or completed translation. In Italy, there are efforts on the way to introduce it as a university course module in these specific standards from next year. In Hungary, it's going to be published by the National Focal Point and the National Office for Drug Prevention. And in Romania, and this is what we're following with great interest, they're trying to make them statutory by law from next year, so they've put in an application. And I'd also like to highlight that there are 2 projects that have followed on from this work, which is always a good sign when that happens. So there is the ECUS project, which stands for EU Consensus on Minimum Quality Standards for Prevention, Treatment, Rehabilitation, and Harm Reduction. So basically the whole area of drug demand reduction. This is a big project in the sense that, and it says this here at the bottom, these ECUS standards, they have been actually commissioned by the EU because the European Commission wants to make a recommendation to the European Council, which is all the heads of state or the senior policymakers, about minimum quality standards in drug prevention. So this is going to have it could have direct impact on EU policy. And so we've been asked to adapt our standards to become the prevention strand of this ECUS standards. Of the ECUS standards. So we reviewed our standards because they weren't interested in a 300-page document like the EMCDDA manual is going to be. So we had to reduce them down to basically 33 short paragraphs. We did this, as I said, through review, and then we had an additional round of consultations to make sure that these 33 paragraphs still make sense on their own. So this has been one major development. The other thing is an international standards initiative, which is still in the early planning stage. Because while we've been doing our European drug prevention quality standards, the Canadians have been doing something very similar. They did a Canadian standards portfolio which covered school-based interventions, interventions in the community, and family-based interventions. And the Americans, of course, always come first. In 2004, they already published their standards of evidence. And there was the sort of idea, could we summarize these international efforts into something called the International Prevention Standards? This is of particular interest to countries in the developing world, for example, that don't have the resources to develop these standards, but that would be really interested to adapt the standards for their own use. And so this shows the international interest that this project has generated. And the International Standards Working Group is a collaboration between LJMU, the Canadian Centre for Substance Abuse, and then some pretty big names like the United Nations Office on Drugs and Crime, the Organization of American States, which covers the whole North American and South America. So they are particularly interested in using this in South America and the Caribbean. We've had, as I said, this is in the early planning stage, we've had one meeting that took part in Washington during a conference, and then the next meeting is next month when we launch the standards. That'll be an opportunity for us to show them what we've actually come up with. So just our next steps. It's that triangle again. So now revisiting what I said we would do, well, we have taken actions to provide a framework for evidence-based working. We have advocated for increased prioritization of prevention, and we have tried to raise awareness of the need for evidence-based approaches. Obviously, the fact that we received funding for this already showed that there was an interest by the European Commission, and with the ECUS project, we're hoping to take this further. But many other challenges remain. What we found, particularly in other countries, because in the UK there's quite a big culture already about quality assurance, quality standards, guidelines, etc. In other countries that's not necessarily the case, in Hungary, our project partners told us that in Hungarian there isn't even a word for quality standards, so they didn't know how to translate that to start with. So people there don't necessarily know what they're for, how to use them. And the things I mentioned before, the skepticism, the diversity of prevention work, everyone who says, oh, could this apply to my project? So phase 2 of our prevention standards, we're about to put in an application to follow on from this work and to ensure its implementation in practice. So to establish the prevention standards further as a brand with our great logo, to produce tools and manuals and to train people on how to use the standards. Because similarly to how the videos, if you just show the videos, people don't actually know what they're about. I think with this manual, there's the same danger. If you just put it on somebody's desk, you know, even just getting them to look into it would be a challenge already. So that's one strain, and the other thing is trialing the standards with real programs, because at the moment it's quite a theoretical document. What we'd like to do, and what people have actually contacted us about, is that they would like to show the world that their great program adheres to all these standards. So that's a great avenue for us for collaboration, to see how programs in the real world are actually achieving these standards and how the standards can be evidenced. And the long-term aim is that every prevention intervention in Europe would have this logo next to its title. So to develop an accreditation system for model programs, for programs that adhere to the standards. And then we could consider these purposes that I before said that at the moment are not feasible. So formal self-assessment, using the standards to base funding decisions on them, and to use them for external accreditation. So thanks for your attention. I appreciate it. It's that sort of hour of the day. If you're really disappointed now because I didn't tell you more about the standards, then we can, of course, give you a copy of the document once it becomes available, and you can email us with any further questions. Thanks.